برضه بنبتدي لأن شعارنا هو الحب، بنقول لقد بدأ وجودنا بالحب، فالنفخة من روح الله لتهب آدم الحياة كانت قمة الحب، واستمرار وجودنا أيضا لا يتحقق إلا بالحب. كنا بنتكلم على psychopathology وقلنا it is a branch of psychiatry that study changed behaviors and behavioral abnormalities, the causes and the pathogenetic stages underlying the development of behavioral abnormalities. Is it clear? قلنا إن psychopathology is two types, descriptive and dynamic. Descriptive is subjective, which is the symptoms expressed by the patient himself, and the objective symptoms is the symptoms that observed by the examiner. And the dynamic psychopathology. The dynamic psychopathology is related to unconscious mechanisms, and at the next time, we will say that in detail and explain how it happened unconsciously as a symptoms. So we have two types of psychopathology. What we are doing here in the clinical case is descriptive psychopathology. Some of symptoms we take it from the patient, which is subjective, and it may be subjective from the observer, and objective, which is quite clear symptom in the patient. Descriptive psychopathology, that is important for us, and which we call it symptomatology or psychiatric symptoms. We ask about what is symptom. The symptom is a disturbance in the function. So when we examine a client, he may be normal or abnormal. If he is normal, he is functioning well, so no symptoms will be extracted from that patient. But it is abnormal, so we will find disturbed functions. The function, when it disturbed, usually it causes symptoms, like the example which I gave you last time, that colon is regulating or enlarged intestine. Its function is to regulate excretion. When excretion increased, we call it as a symptom diarrhea. And when the excretion is stopped, we call it, or reduced, we call it constipation. So, as a function of the large intestine, of regulation of excretion, we have symptoms either constipation or diarrhea. So, in our psychological functions, we have the same. We have the same as the function. When disturbed, it gives symptoms. When we have symptoms which came in a group form and found in special cases like Down syndrome. This is called syndrome. Down syndrome, we observe the symptoms and whether what subjective told by the patient or we observe it, it is a group of symptoms that comes together. When we find a cause for this syndrome and it will be a definite cause, then we call these symptoms and this syndrome as a disease, like diabetes. Diabetes has a limited confirmed cause, which is reduction of insulin secretion. What are symptoms in psychiatry? Positive symptoms, negative symptoms, cognitive symptoms, aggressive symptoms, affective symptoms, and somatic symptoms. If we goes with this patient, we have aggressive behavior, aggressive symptoms. We have negative symptoms, which is social withdrawal and the lack of self-care. This is negative symptoms. Aggressive behavior is positive symptom. Depression is positive symptom, and the affective symptom is in the same time. Delusional ideas is positive symptoms. It's not affective, but it is positive symptoms. And somatic symptoms were in form of just lack of appetite. But this division of symptoms is disturbing and not accurate because we have no system to work on it. After we examine and we take the history, we can say this positive, this negative, this cognitive, this aggressive, this affective, this somatic. But on doing the history and the examination, we can't have a system. So I assigned this system. First, disturbed psychological functions. Second, disturbed habits. Third, social impairment and occupational deterioration. This is my own system in taking history and examination of the patient. Because in this system we can't forget any function and we can't neglect these habits or social impairment or occupational impairment. What are psychological functions? I talked with you the last time about simple functions and the compound psychological functions. The simple functions, it is present in Hamouda's model of simple functions. And each function has each disturbed function which presented in symptoms. So each function, when it disturbed, it gives us group of symptoms. And we will see this compound psychological function, just like orientation, learning, intelligence, and judgment. These are compound functions, because this orientation has to be conscious, attentive, and perceptible. And you can talk. You must have ability to talk, to express this orientation. So it is a group of function. It's not just a function. But this consciousness is just function. Attention is just function. So I call it simple functions. And this is compound function. What is consciousness? Could you define it, Farid?
A state of awareness which enables
the person to be aware of himself and the surroundings. That's what are the symptoms of disturbed sleep. We talked about sleep and the stages of sleep. So the disturbance of sleep gives symptoms. Maybe hypersomnia, which means increased sleep, or narcolepsy, which is involuntary short bouts of sleep. Somnolence, dizzy sleep that can awaken from it to normal consciousness. Dizzy, but when it aware, it will be in normal consciousness. What are symptoms of disturbed consciousness? We talked about symptoms of sleep as a normal function. When the sleep as a normal function disturbed, it will give the previous symptoms. But consciousness, when it disturbed, it will give us the following: quantitative changes in form of coma vigil, stupor, confusion, cloud consciousness, torpor, and trance state. Where is Mustafa? He was confusion. He was talking about confusion. And qualitative changes in form of dissociation, dream-like state, restriction of consciousness, somnambulism, and hypnosis. These are quantitative changes, and this is qualitative. This is change in quantity, and this is change in quality. Quantitative change, we talked about it the last time. Coma. This is, you see, this is comatose patient in intensive care unit. Coma vigil, which is open eye coma. Stupor, we talked about it last time. Confusion, we talked about it, and we say that it is present in delirium. Cloud consciousness, torpor, and trance states. And we come back to the qualitative changes, which is dissociation, dream-like state, restriction of consciousness, symbolism, and hypnosis. Dissociation. Some of psychological functions are acted separately, like movement. Usually, the children at age of 8 or 10 years, usually during sleep, you will move and go around in aimless movement and come back to the bed again. We call it dissociation in movement. If the change in memory, we call it the dissociation in memory, as we will see in the next. Dream-like state. The lack of consciousness as subjective experience with increased threshold of perception to all stimuli. So all stimuli has increased the threshold to perceive it. With lack of orientation for time and place, but oriented for person. This is dream-like state, lack of consciousness as subjective experience. We said at first that symptoms may be subjective or objective. This is a subjective symptom. This is a subjective experience with increased threshold of perception to all stimuli. So it is lack of consciousness in a form like dream state. Accompanied with visual hallucinations. Visual hallucination is objective symptoms or subjective? It's subjective because the patient tells about these symptoms. So accompanied with visual hallucinations of small animals with fear. With fear. Fear is a feeling, so it is subjective also. Rarely accompanied with auditory or olfactory hallucination. And it is usually associated with temporal lesion. You know that the cerebral cortex is divided into frontal, parietal, occipital, and temporal. So this lesion of temporal will give this symptom. Restriction of consciousness. Patient's mind occupied with few situations and ideas. Is it subjective or objective? Patient's mind occupied with few situations and ideas. Yeah, objective. Because you observing it, but the patient can't tell that his mind occupied with few situations and ideas. But on examining him, he is occupied with these few situations and ideas. He is talking with you about this and the impaired orientation for time and place. So this is objective. Yes, you examine and you observe this symptom. Twilight states. This restriction of consciousness includes twilight state, which is pathological constriction of consciousness that prevent normal consciousness and behavior. So it is pathological. And you will observe it, the twilight state, and it occurs in epilepsy and hysteria. In hysteria, it has unconscious motivation, and it's called the catathermia. And this is a very known symptom in hysteria. And it's important to know that catathermia is some form of disturbance in consciousness, and it has unconscious motivations. Unconscious motivation here is a dynamic psychopathology. You see, it's from unconscious motivation. When you discover that this twilight state, which is pathological constriction behavior and has unconscious motivation, so you will be in the field of dynamic psychopathology because you observed that this symptom is appearing due to unconscious motivations. And you know that we have in hysteria primary gain and secondary gain. So we have unconscious motivation to the primary gain when the consciousness is changed in a hysterical patient with unconscious motivation. So the change of unconsciousness here is the primary gain, and secondary gain which the care and attention which comes from the surroundings and his family. Fugue is called wandering, is accompanied with amnesia up to a certain limit. You know this actor? Do you know him? Do you know him? Yes. This is Fadi Muhandis. This series, and he was the hero with يونس شلبي. يونس شلبي كان اسمه حيرم في المسلسل ده، وكان فؤاد المهندس بيقوم ويمشي ويتحرك ويروح ويعمل حاجات ويرجع وهو ايه؟ نسيها تماما. فهو ده بقى الايه؟ الفيوج. Wandering accompanied with amnesia up to certain limit. Somnambulism. This is the walking of a child during sleep. Somnambulism. But if it happened in an adult person, it's a symptom. It's a psychiatric symptom. But if it happened in a child, usually we call it as just immature. Just immature control of the brain to the human being, because it's still immature brain. So if it normally happened in children, but in adults, it is pathological and found in schizophrenia or schizoid or epilepsy. And I faced cases with this somnambulism. He was a man working in Al-Hussein Hospital, and he presented his young man son, and he said that he is moving during his sleep and going to the balcony and wanted to go out from the balcony. The father catch him and gave him to me, and I diagnosed it as epilepsy and confirmed it with EEG in lab sleep. In lab sleep, do you know the importance of lab sleep? So when I diagnosed him, I gave him anti-epileptics, and he became very well. Hypnosis is induced change in consciousness in case of suggestion, because hypnosis is a suggestible, a change in consciousness, and it is self-suggestion. If the patient is in a transference relationship with the therapist, and he is in confidence with the therapist, and the therapist gave him suggestion to go in a sleep, just relax, just your eyelids are very heavy and you are going to sleep, relax, leave yourself to go in sleep, so he will be, so this suggestion to go in sleep. Breuer and Freud, in their beginnings, they were treating patients with hypnosis, as I told you before. It's not a real sleep. It's a trance state or dissociation. But it is not real sleep because the changes in EEG through hypnosis, it is just like the waking state. It's not like sleep state. So it is not a sleep. And it is the trance state or dissociation, and the EEG is just like the waking state. We can summarize what we have said. In consciousness disturbance into symptoms, quantitative changes, coma and coma, vigil, stupor, confusion, cloud consciousness, torpor, and trance state. And in qualitative changes, it is dissociation, dream-like state, restriction of consciousness, somnambulism, and hypnosis. And we come to our River Nile, which is the artery to our life, and we hope it to continue. And thank you.